Yep, there we go. Okay, so welcome back, everyone. I have the honor of being the moderator and presenting here. So for the next hour, we're going to talk about value for money assessments. Obviously a topic that a lot of people are interested in. And for this, I really looked through the agenda, saw all the titles of all the great talks, thought those are great value adds, and put something together. I'm Jonathan Campbell. I have to introduce myself. I'm an assistant professor here at McGill in the Department of Medicine and Global Public Health, and I'm the associate director of the International TB Center here. Pure economists wouldn't call me an economist. Pure epidemiologists wouldn't call me an epidemiologist. I'm kind of straddle around. Done a lot of work with WHO and World Bank on tuberculosis primarily, but pivoted to COVID. So, and I head the cost effectiveness working group. If I can figure out this, which is, I'm clicking. All right, whoops. Well, I went through the disclosures. Anyway, received funds, CITF paid me to do value for money assessments on your projects. Some of you might have opinions of me on that. I've received no funding for the work presented today, which I'm going to talk to Tim about after. And the content presented here is the result of collaboration with several others, so I'll name them explicitly: Sherry Kelly, Caroline Wagner, Kate Hankins, Alton Russell, Prativa Baral, Varun Anapindi, Olivia Oxlade, Doug Manuel, Chantel Pambran, and Tim. Okay, so I'm presenting on behalf of the group, so criticism should be diffused among us, not just directed at me. All right, so just to kind of place this in context for what I'm going to talk about, defining points of the network, I'm obviously coming at it from the aspect of, hey, we got a network together, right? So we're talking about a pan-Canadian network of institutions that would have residual blood products, either through tests or donation. Okay, the process that I'm going to be working under is that the institutions within this network contribute a proportion of the residual blood products to a national biobank. Physical specimens remain in province or territory where collected, either at the institution or at a central one. However, the metadata on specimens, so basically it's a searchable biobank that's held hopefully centrally with demographic and clinical info. There's a lot of talks that are going to go through governance, linkage, consent, representativeness, capacity. Those are going to be discussed elsewhere. As I said, I'm going to come at it from the viewpoint that we've addressed them. They're all obviously very important to realize the true value of the network. Okay, so if you go on FAC and you look up public health surveillance networks, there's 32 that are explicitly listed online. They're scattered through here. There's also about 70 diseases in the notifiable disease registry. A couple are duplicates. There's non-specific hepatitis, hepatitis A, B, or C, etc. But these are kind of all maybe not useful for serosurveillance, these networks, but they all act as vertical structures. Right? This can lead to some duplicated efforts and redundancies where money is being spent on multiple programs where pooled resources to do this across programs in a horizontal structure might actually provide cost efficiencies. So what's the cost to these? I went through the FAC budget in great detail, at least whatever's public. It's tough to parse. Budget line items for surveillance fall under a $200 to $300 million budget for infection prevention and control, it seems, though clearly only a fraction of that would be spent on these activities. Compiling data is obviously under the provincial and territorial purview, which then gets fed up to the federal level. So how much are we spending on this? I'm not sure. If anybody knows, please tell me, because that would obviously help the value case. Maybe nobody wants to talk about how much they spend because it's a lot. Pathogen agnostic serosurveillance can replace, obviously, some of the activities done by these networks, not replace them entirely, and provide complementary information. Okay, so this is not a replacement network, it's a complementary one. I think that's how we should look at it. Okay, there's clearly no substitute for serosurveillance. It's a critical component of infectious disease surveillance activities. You can look at burden of vaccine preventable diseases, identifying risk groups, understanding vaccine protection, support modeling and economic evaluation, looking back, looking forward. It's been implemented using residual sera in a few countries. This was mentioned earlier in the morning. It's not necessarily a new idea. This paper is 12 years old, talking about the value of seroepidemiology. Okay, we're not reinventing the wheel here. We've known this is an important thing that we should be investing in. We just haven't done it. So there's also unfavorable cost benefit for rare and emerging diseases, right? If vertical structures for even common diseases can be cost inefficient, right? Putting in entire surveillance networks for rare and emerging diseases are going to even be more costly. Plus, you're only going to pick up those who present to the clinic with a clinician with high enough suspicion to test. Okay, a pathogen-agnostic surveillance network relying on residual bloods could perform more comprehensive surveillance through economies of scale. So lower cost of doing all of these things individually. Not saying it's going to be cheap per se, but it will be cheaper than monitoring all of these on their own. We're talking about babesiosis, mpox, malaria. Malaria we monitor through severe cases. How many are we missing, right? Lyme disease, echinococcosis. I think I'm actually pronouncing these things okay. I had to look it up. All right. We also, it's our Canadian nature here with surveillance, right? We're passive. Okay, this is a graph here. This is a graph I compiled for tuberculosis, right? I work in TB. I wanted to see what the heck's going on in our surveillance. We waited like 5 years one time for a surveillance report from FAC, right? The top line is Canada, right? Delays to publication of surveillance data. The bottom is US. US gets their annual surveillance reports out, top line data within 3 months. National view of TB, 3 months. Full reports within 10. Canada, you got up to 60 months at some points. And then those quicker years, they barely published anything. I gotta tell you, those reports are scant, right? So infectious disease surveillance here largely is a passive effort, made difficult, 13 provinces and territories. The US has 50 states, right? Plus some whatever the 50 states, no? And then a couple of things, yeah, all right, I'm not off. And like Puerto Rico and places that they claim but aren't states anyway, so they can avoid paying whatever. This kind of leads to immense delays in surveillance reporting, right? Issues for programs to make decisions. These are like historical records now. We all look back and say, oh shit, we should have done something in 2020, but it's 2025 now. So, all right, not really something we can do today. We lack vision, okay? Our notifiable disease system, of which we have give or take around 70 notifiable diseases, by design misses people who are asymptomatic, have non-specific symptoms, who never present to clinic, are not tested, HIV, Hep C, SARS-2, dengue. We've discussed all these before today, okay? I'm not going to beat it to death. And do we really know the size of the vaccine, of the susceptible population for, diseases we vaccinate in childhood, okay? And I don't need to repeat this. Do we need to repeat the mistakes of the past either, right? We've known surveillance has been a weakness, things we can improve upon, SARS-1, H1N1, recent talk about needing better surveillance for pathogens, okay? I think we're all here because we believe in it. We don't want to repeat the mistakes of the past. Okay, so what's it going to take? I'm not here to provide you a dollar figure right now because that's a little bit tough, and I'll get into why. Okay, but the upfront investment might not be as much as we think, okay? Because network institutions, at least as envisioned by Humanet, who said, hey, I'm a provincial lab, I would like to partake, right? They already have biobanking infrastructure. There's some already there, or they're linked with a central institution in the province or territory that has one. Okay, so large investments that you're looking at in the hundreds of millions sometimes to set up a full national biobank can be avoided. Okay, we're talking about costs on the margin, all right? Adding a little bit of, new freezers, retrofitting space, et cetera. Okay, some institutions already have high throughput machines for analysis. We don't necessarily need to buy these machines, okay? Additional machines that do need to be bought can be crowdsourced and shared throughout the province. Okay, value of scale efficiencies again. So these marginal costs, I'm not saying are not important, but they're definitely not as big as starting from scratch. We are definitely not starting from scratch here, okay? And what's gonna happen every year? Well, you can look to the UK Biobank and how their budgets each year if you want to know. We got to spend money on governance, ethics, data management, sample transport from different contributing institutions, site-specific management, research analysis platform, if that's where we're going to go with this, annual operating costs in terms of replacing and maintaining materials, sample processing, PPE. I can go on and on. There are annual recurring costs. And the UK Biobank, their most recent financial report said about £25 million in expenditures, right, that they had. Big biobank, right? Well, if we want to get to there, it's going to be expensive to keep running each and every year. But the biobank has had massive value, right? They just, I think, looked at predictors of dementia using the biobank and could predict 15 years in the future. Anyway, so Things that you maybe didn't think you could do with a biobank, they could do after it was set up. So there's unique challenges in valuing surveillance networks, okay? In traditional return on investment or value for money assessments, we typically look at disease-specific activities. I'm gonna walk us through TB. That's where I work, and I happen to be just trying to write up a paper looking at return on investment, so I can walk us through this. Health investment in tuberculosis, okay? For example, to implement and scale up tuberculosis screening and prevention activities. What does that lead to? Reduced incidence of tuberculosis, transmission, post-TB sequelae. That leads to a return to society, which you can value as reduced cost of diagnosing and treating TB and lost productivity. I don't know if anybody likes bugs. I'm kind of regretting putting this on, these analogies, so if you don't, I apologize. You can think of it like a worm, okay? The health system investment goes out one end, and there you go. The societal goes in one end, comes out the other. But a surveillance network is different, right? It's not just linked to one value add. We got like a centipede or a millipede or something, right? There's so many areas that investing money into a serosurveillance network can lead to. And hopefully I'm going to go into them today. Okay, so what sort of return on investment can we expect from investing in formalizing an integrated serosurveillance network in Canada? It obviously depends, right? How ambitious are we? What are we doing with the data? Will we use the network to its full potential? Will the data it generates be used? Right? If we can generate a ton of data that never actually leads to public health action, have we realized the value of this? You can think of the event as a PCR, right? It was initially developed specifically for sickle cell anemia. Do you think they were there being like, this is a big value proposition, we're going to make PCR? Probably not, right? They didn't recognize its true value until everybody got their hands on it and said, wow, this could be a really impressive technology. Serosurveillance could be the exact same way. Right? What sort of value could it provide? Do we even know yet? Right? Maybe we'll find out new things we can use it for down the line. Machine learning, AI, going to throw out buzzwords like that. Things that are smarter than me, probably all of us in the room, eventually will be able to use the data collected for good. So this is how we kind of had structured it in a very simple framework, looking at some of the value propositions, more from a public health purview. I'm going to get into some other specific value adds. We have available inputs already for us, right? Blood samples are already collected. We don't have to go and pay for them. Okay, we don't have to have patients come in. They're sitting there. We have technical infrastructure and lived experience through the CITF. Okay, lots of know-how dealing with privacy assessments, data management, data sharing. We're going to need some new inputs. I've highlighted the physical biobanking infrastructure that we'll need in maintenance, money for sample storage and analysis, governance and oversight, data management, the stuff that we know we're going to need, but again, these can be on the margin. Fed into a national surveillance network. You know, we have example use cases, many brought up today, endemic disease surveillance, emerging pathogen detection, disease biomarker discovery and evaluation, surveillance for vaccine preventable diseases, burden of disease estimation, chemical and environmental contaminant surveillance. That's just like 6 of a numerous number that can all then feed into public health action that would help us respond to public health threats, work for pandemic prevention, public health planning and decision making, research and development advancement, improve population health and productivity, right? These goals that as public health professionals we all want to achieve or work towards. So, some value opportunities. Okay, burden of disease. We have the chronic disease surveillance system. Every province, territory uses health admin data, feeds it in, estimates about 20 different chronic diseases, I believe, right? Okay, residual blood samples could be leveraged for certain diseases to capture the undetected population that aren't picked up by those health admin databases, right? Notifiable diseases, we have 70, as I said. These are based on confirmed or clinical diagnoses. Blood products can help identify the undiagnosed burden, right? We use statistical models right now to try and estimate that underlying prevalence of those undiagnosed. We could use blood products to help complement those analyses as well. It's going to be a bit more expensive, obviously. For chemical and environmental contaminants, right? This is going beyond infectious disease, things that we are concerned about. Human exposure to chemical and environmental contaminants, we can monitor these through blood products. We had basic location data from specimens that can help identify areas where more intensive environmental or population sampling could be done. And of course, we need to get the infrastructure in place to do this, but this is a potential value opportunity. We can use it to help characterize health disparities, right? Even basic demographic information linked to residual blood products, age, sex, ethnicity. I know CBS collects race data, I believe. Forward sortation area, right? Residual bloods can provide an opportunity to identify or zero in on health disparities. Disparities in underdiagnosis or recognition of certain health conditions can be better recognized using residual blood products. Are there population groups who are systematically missing? Are there areas where tests right now we don't have infrastructure to maybe test them or work them up properly, but they have residual blood products available that could be tested? Population health surveys. It's a big undertaking to do a pan-Canadian prospective survey, right? How do you ensure it's representative, right? It's a lot of time and money, right? You could achieve representativeness with an integrated serosurveillance network. You could. There's not going to spoil the talk that will come up. But if you could get a good number of institutions, at least one from each province and territory, and you understood the population it served or that the residual blood products it was collecting, you could develop a sampling scheme that could approximate the Canadian population, right? We're going to take 5% of samples collected by antenatal for biobanking. We're going to take 20% of the samples collected in Yukon for biobanking, for example. You could develop these schemes to make them representative so the biobank itself is not just every sample taken in Canada, but is hopefully a more representative sample than we could make otherwise, right? And it can add significant value to health surveys, right? If you could include this with the CCHS with a tick, I consent you to go into the National Biobank to test my blood for XYZ. That's something that you could link to these surveys. You don't have to have people go into clinic to give blood. You don't have to do these things that cost people time, right? Time and money. Blood products are already there. We can work with them. Contribution to global serosurveillance activities, right? If we want to go beyond our borders, right? A rich library of blood specimens could be leveraged to contribute to this. Monitoring of population level immunity to priority diseases, how do we compare it to on the global scale? What changes do we notice here that have implications for our neighboring countries, for countries elsewhere? Right? Emergence of diseases with pandemic potential. Right? And there's a few groups that we could potentially contribute to, and I'm not going to go and spoil again the presentations. This is another title of a presentation that I took and put on a slide. The ability to look back and learn, right? This is clearly an underappreciated advantage of having a biobank that's already up and running, that's characterized, right? You could provide immense value because you can look back and retrospectively evaluate the evolution of emerging infections. Where are the susceptible groups? Where was it? How did it start? How did it spread through a population? Especially with a biobank that's been up and running and you have repeat donors to it, right? Understand how endemic infections have been progressing through populations. Better understand risk and correlates of protection. Can you identify biomarker patterns associated with risk and protection to support precision immunology? Right? These are very kind of abstract when you say it out loud, but have potential in many, many disease areas and public health activities. And of course, economies of scale. Right? Conducting serological testing at centralized provincial or territorial sites can leverage economy of scale because we have a lot of centralized knowledge and skills, infrastructure, right? Reduce costs. Centralized know-how on serological testing means simpler standardization in assay choice and procedure across network institutions, more consistent quality. Hopefully, if you have a network that's up and running and working together, you don't have 13 provinces and territories using the same test slightly differently with different values that are, you need harmonization software to interpret. Centralized infrastructure means high throughput systems can be employed. Okay, you don't need a bunch of small, less efficient systems. They need not be purchased for all network institutions. It can also improve the speed at which specimens are analyzed. And of course, that helps benefit cost efficiencies. Also be a critical player in assay development, evaluation, and standardization. Network institutions and the biobank, they help create. Well, house these well-characterized specimens that make them ideal for development of reference panels for assay development and evaluation. The continuous biobanking of specimens supports the ease to which both positive and negative specimens and reference panels can be developed with representation of Canada's diverse populations and geography. Such materials are obviously key to both develop assays and evaluate those brought to market. Plagued by different assays and protocols during SARS-2, interpretation of identical tests performed became difficult, which I just mentioned. So there's obviously value to be gained by a network with fewer players in terms of standardization. Now, the health workforce. A big network like this, especially one that's active, right, helps maintain core competencies. Obviously learned a ton during SARS-2. I don't necessarily consider myself a healthcare worker, but because of SARS-2, I learned a ton about infectious diseases that weren't tuberculosis, okay? A lot of people here have had probably unpleasant experiences learning about data sharing and privacy assessments, right? How their diagnostics and therapeutics are standardized and developed, surveillance, research. These are big competencies that we need in the health workforce that you gain in an emergency that quickly you lose during peacetime. A network like this that's engaged in constant serosurveillance and used for research can help maintain these. Relatedly, you have retention and development of highly qualified personnel, right? We can serve as a crucial conduit for the exchange of ideas and information, playing a central role in their development. Research and routine epi-analysis and surveillance and the laboratory work provide opportunities for people within the network to support the retention of personnel. We scaled up for COVID, then you have to let people go once it becomes deprioritized. Right? If you have some activities to keep these highly qualified personnel on and maintain their skills, it's very valuable. Okay, and obviously can then evolve into an important hub for public health and biotech research and development, filling key needs here in Canada, and this can help keep capacity maintained during our business as usual time. Major research platform, I think this is one of the values that we all can see of a major serosurveillance network, right? Obviously has a rich and representative library of products. This is the Biobank UK, right? With our varied skills and members, it's an ideal training environment, right? So we can train the next generation of researchers. Opportunities for individuals to develop skills using the information contained in this network through internships or training contracts. Academics and industry can work together, leverage the network to make requests to access specimens for research. This is also an important way to have some cost recovery, right? UK Biobank has an exact thing set up that works on the margins. So it's not necessarily to fulfill the day-to-day, but the cost recovery model is for all the marginal costs associated with research. And of course, experience for the next emergency beyond all the other benefits. There's immense value in having experience conducting these activities. We took a look at time from funding to results across studies funded by the CITF. Only singled out one, which was the CBS study. Okay, funded April 2020, top line results available August 2020. Nearly 3 times faster than every other study that was funded by CITF. Okay, and I would bet dollars to donuts, so that's because of experience already doing this type of surveillance, having specimens on hand and ready to go. Representativeness is obviously an issue, which we've discussed a few times here, but within a network you could potentially address. So experience pays dividends in terms of timeliness. Okay, so some explicit value for money propositions that I'll quickly go through. Waning vaccine-induced immunity, I think has been discussed a few times today. We have sometimes poor understanding of long-term protection against some vaccine-preventable diseases such as measles. While immunity is likely to be lifelong in many, it's unlikely to be the case in all. The most recent CNIC said that 80% of children by their 7th birthday had 2 doses of measles. That's a substantial fraction under-vaccinated. Right? We might have pockets of susceptibility among those previously vaccinated, and we're unaware of the demographics or characteristics of this ever-growing susceptible population of unvaccinated individuals to measles. Most costs associated with these outbreaks don't come from direct medical costs, right? Investigating outbreaks of these diseases is very expensive. 2/3 of costs are the public health response to it, right? Another 25% or so is productivity loss, and then a small amount is actually direct medical costs of care. Okay, an outbreak of 10 people could cost around $650,000. 113 cases in 2019 probably cost around $7 million in productivity loss, public health response, and direct medical costs. These are not inexpensive things, right? And if you say it's $25 million to run the biobank each year, if you can use that data to catch up on vaccinations of our under-vaccinated population, you could avert or minimize some of these costs. Of course, you have to use the data, right? So there's also questions on seasonal need for vaccination or revaccination, right? Uncertain on the frequency and timing of vaccinating for SARS-2 among immunocompromised populations. Okay, there's always sometimes always discussion on influenza. Should you be doing a revax in particularly susceptible groups, halfway through the flu season? An integrated network like this could potentially provide insight into population susceptibility prior to and during peak periods if it's up and functioning well, right? Timely analysis of these kind of samples could be done in a network like this. So there's significant potential value if we could identify groups where vaccination efforts should be focused, or if we can inform vaccination guidelines. Cost of COVID-19 hospitalizations from CIHI, about $25,000 per stay. Post-COVID condition per person is about $10,000 in the first year. Influenza hospitalization costs about $15,000. Okay, you could obviously weigh these costs as those averted against the cost of testing residual sera to inform such efforts, and then against the cost of a vaccination campaign, right, which could be in the realm of $50 to $100 per dose administered at the end of the day. And of course, we're not just talking about the cost of the vaccine, it's all the efforts that go into planning that campaign and getting the campaign and getting it into arms. Okay. Of course, it's difficult to link it to a hard outcome at the end, right? Can improve efficiency of resource allocation. Where best to place our health care dollars is obviously an ongoing and never-ending debate. We're here also to try and make a business case to get those precious health care dollars to fund this. Right? If they weren't scarce, we wouldn't have to discuss it. Diabetes has a prevalence of 9.3% as estimated by the CCDSS based on health admin data. Integrated network could complement such data and potentially identify those at highest risk of diabetes, quantify the burden of undiagnosed diabetes. The UK Biobank suggested about 1% of people in their biobank had undiagnosed diabetes, and using longitudinal samples found that most of them never ever got diagnosed. Annual cost burden in Canada for diabetes is on the scale of 1.5 to 2 billion, right? Among those we know have diabetes. So data from the network could help motivate further investment in diabetes prevention or better target interventions to improve the efficiency, potentially. Emerging infections, vector-borne diseases, right? Saw the thing on Hep C, right? How many do we know? How many have care? How many don't we know? It's a large burden. We only know a small fraction of these, right? Limitations in clinician suspicion, frequency of asymptomatic infection, lack of healthcare seeking for nonspecific symptoms. It's likely that blood-based surveillance could detect changes in epidemiology before clinical diagnoses could. If we can detect these changes earlier, we could prevent things and have a quicker response and allocation of resources. Okay, and obviously being ready for the next epidemic, pandemic, right? Rapid implementation of serosurveillance by CBS early in the SARS-2 pandemic clearly paid dividends, 4 months from funding to results. What value would an integrated serosurveillance network have provided in March 2020 if we had more than CBS on board, right? This is the clear counterfactual we're looking at in emergency times, right? What would the added value have been if we could have improved our risk stratified rollout of vaccines? How many infections, hospitalizations, post-COVID conditions, deaths could have been avoided, right? Modeling is particularly adept at this, right? If a national serosurveillance network could have prevented even 1% of all COVID-19 cases, if we had this up and running just 1%, okay, the savings from a societal point of view would have been $70 to $500 million per year just on post-COVID condition costs alone. Okay, you're looking at direct medical costs of $80 million in terms of hospitalizations, and the more broad societal costs of symptomatic infections, missed work, staying home, transmission. Those that don't get sick enough to be hospitalized are likely far greater. It's serious value. Okay, and of course, you can use this to support epidemic modeling and forecasting, understand population burden early on when acute testing systems get overwhelmed. PCR capacity is only so high. You have, of course, a large undiagnosed population, support our understanding of protection, vaccine allocation, prioritization, evidence towards the effectiveness of different NPIs, for example, things that were contentious that maybe an integrated serosurveillance network could have provided some insight on. Especially if it's integrated across Canada, right? You have natural experiments that are done province to province that could be evaluated in this way. Last slide. So there's, I think, clearly a need here. Everybody in the room, I don't think I'm arguing with people here. We all believe it. For comprehensive serosurveillance in Canada, obviously all countries, pathogen agnostic systems benefit from economies of scale and address some inefficiencies of vertical programs. Blood products are already collected, no need to recruit participants. We already have some infrastructure in place. We're talking about costs on the margin, potentially saving hundreds of millions if we were to start from scratch. Clearly multiple value pathways in peacetime. Of course, this requires us to leverage the network to its full potential to unlock these value pathways. You might prioritize some over others, obviously. And emergency use cases are plentiful, and experience during peacetime supports a rapid scale up in data generation when the next emergency happens. So don't repeat the mistakes of the past. We don't need to rebuild things every 10 years here. There's clearly value that can be added by maintaining it. And I'll stop here. Clearly I'm pressing the wrong button. There we go. Oops. For a panel discussion, so thank you. I will introduce the panel members. Okay, so I'm going to invite you up, Caroline. Caroline's an assistant professor in the Department of Bioengineering here. She did her PhD at MIT in mechanical engineering. It's very impressive. Did her postdoctoral training at Princeton. Jesus. In the area of mathematical disease modeling, research program focuses on understanding the interaction between pathogens and biological fluids and modeling the effect of such interactions on population level disease dynamics. She's a member of HumanNet and part of our working group here. Sherry, who is online, I think. If we can, is she on the screen? Maybe, not? Yep, there she is, at least on my end. Can she go up? I see her here. There we go. Yep. Newly, first Canadian, senior editor at The Lancet. Okay. Yep. Holds a PhD in ID modeling and has worked for over 20 years to accelerate global health responses for HIV, TB, malaria, maternal child health, and COVID. Clearly gets her hands dirty in a lot of things. Lots of experience. Areas of interest include disease prevention, health economics, climate change, and health, and has led substantive public health projects in 30 low and middle income countries to inform WHO, Global Fund, World Bank, CDC, and Bill and Melinda Gates Foundation initiatives. And finally on the panel is Kate, who I've been told not to introduce because we all know. So thank you very much. We're just going to have a brief moderated discussion before questions to me and anyone else up here, of course. So is there a volunteer on the panel here for me to poke at first? That face, Caroline says it's going to be you. Okay, so you're clearly an infectious disease modeler. I highlighted a few value adds here, but what value do you think this network, if it comes to its full potential, could provide to people like you?
So you said I'm clearly an infectious disease modeler, and I think similarly how you said you're not an economist or infectious disease, I sort of straddle the engineering and disease modeling world. But in any case, I thought it comes back a little bit to the point that we heard on a previous panel, I think, where there was this contention about do we present things as research or do we present them as public health? And from my perspective, I think I feel a little bit out of my league here, and I'm learning a lot about sort of the details of collection and more the public health side. But from my perspective, I think it's so clear that the data that HumanNet would allow us to collect would be so applicable to so many research questions. I mean, from my perspective, that's why I'm so keen on it, and I want to support its development, that for some ways in my head that makes it clear why, yes, obviously there's the clear public health and surveillance aspect, but it would inform so much from the modeling perspective as well, which I think is for me why the link is so clear. So there's actually a panel tomorrow on the usefulness of Sero data in modeling, where I'll try to speak to some of this more coherently and with slides and everything. But the work that I do on the more bioengineering, biophysics side we think about how pathogens move around through biofluids and infect cells, and mucosal antibodies play a role in that, other antibodies play a role in that, and learning, I think it's a bit of a stretch in terms of maybe what residual blood sampling could allow us to collect, but better pictures of kinetics of antibody dynamics, things like that would be so useful for guiding models like that. We have, and I'm talking to colleagues, this is not a unique problem to us, but trying to estimate parameters related to anything like infection or transmission becomes so hard when you don't have any idea of true case numbers. And I think that's true for anyone doing modeling in this pandemic context. Sure, we can calibrate to hospitalizations, but in some ways our estimates of parameters related to infection are not that useful because we don't know what true infection numbers were at the end of the day. So I think there's so many ways where Sero data could really help inform models, improve their predictive power, and I just want to push that to me, there's no contention with the research side. I think these data will feed so naturally into so much of that.
Great, thanks Caroline. I'll switch gears to you, Kate.
Okay.
If that's okay. I'm sorry. I touched ever so briefly on the network potential beyond infectious disease, right? And I'm interested in your global view and vast experience on where do you think the greatest value lies outside the infectious disease space? Where should we be pushing HEMA at?
Yeah, so I sort of, I looked at what we have. We have the Canadian Health Measures Study that goes out every 2 years and collects data. It's missing data from a number of different populations, incarcerated, military, on reserve, and so on and so forth. But if you wanted to ask a question, it could be 2 to 3 years before you had an answer. So I started thinking of the non-infectious disease, and I was thinking of the things that we're concerned about because they're endocrine disruptors, and they could be affecting fertility in the population, like the dioxins, the PFAS, there's a whole list of them, atrazine, perchlorate, so on and so forth, and trying to think about, and I looked to see, did the Canadian Health Measures Survey look at them? They looked at some early on. 99% of the Canadian population, according to them, between age 3 and 79, had PFAS in their blood. These are all over the place. Now, there have been regulations brought in, but it hasn't come down very much. And as far as I know, I couldn't find any other monitoring system that's looking at that in particular. And I started thinking, okay, so that's one thing, sort of these plastic, these chemicals, there's something like 15,000 of them, and new ones being introduced all the time into our food or cosmetics or clothing or whatever, and I don't think we have a feel for what the impacts are going to be on human health. There were other things, you mentioned diabetes, and that's obviously something of concern if you could be picking up undiagnosed cases of diabetes early. There are things like you could look at, we talked about wastewater early on as kind of being an early signal. I mean, there's some work going on about whether you can look at liver disease. Are there metabolites you should be looking at? I tried to see, so that's the biomarkers for NCD, the environmental contaminants that are related to our way of life, but also, no doubt, the climate crisis interjects with them by creating conditions where they might be retained longer in fluids and so on. And, just trying to think, we could make good cases, I think, for the non-infectious disease. We're coming from pandemic, infectious disease, have to work fast, but I think we need to look at, okay, what else is going on health-wise in the population that something like HEMANET would be able to contribute to an early warning system.
I couldn't agree more, Kate. Thank you for those perspectives. Last question because I know there's question period and I don't want to keep you guys all inching, waiting to ask questions. So I'm going to switch over to Sherry, who's got her vast experience and especially experience in Canada as well at FAC. I'm wondering, Sherry, can you speak a bit to, we're going to go through a lot of work if we can get to the end of HEMANET, right? A lot of efforts, barriers that we see right now that limit HEMANET's potential are going to be broken down. What kind of externalities might come out of the woodwork if we can bring HEMANET together and get through these privacy, data sharing agreements? Like what opportunities beyond, what we can see for HEMANET's potential could we see in Canada?
Thanks, Jonathan. So as we know, the world is flat, and especially from COVID, that pathogens don't respect borders. So outside of our Canadian borders, a network like HEMANET would allow linkage to other active regional and international serosurveillance networks and groups. So like Caroline was saying, and Kate as well, the early detection systems now are things like wastewater, but there was even an article that came out about, airplane bathrooms are basically going in to detect people who travel a lot. But I mean, if we can have an in-country active surveillance system, then we can link with other international groups and be on dashboards, then Canada can take a bigger part and be a better and more active player in the role of informing both, the trends in Canada, but also the trends regionally and abroad. And I think that that's something, I know from experience working, in the UN, when we were having Canadians report to us, just on an aside, a few years ago, they sent, we need a digital reporting system that's quick. So this would help also align with upskilling of health for the workforce with international standard best practices to retain that workforce. Like you touched on, of course, the diagnostic assays, we want to help develop and improve them. But if we're linked into this larger groups, we can share information in terms of the international standards. And Canada can actually then continue to better inform these international procedures. So there are things, like lab capacity sharing, but really ultimately contributing to, in a more meaningful way, to global health research, global health reporting of disease, et cetera, and just have an evidence base that influences policy change. So if you're at home and thinking, well, why do I care? This is important in terms of valuing the protection of all Canadians during peacetime and health emergencies, like you said. But really, it's the day-to-day. Just one striking point that Kate mentioned and I heard is the average person eats a credit card size of plastic each week. So do we know in Canada, is that true for us, and what's the impact? That's just one example, but really in addition to the pathogens that just can move and change so fast, we really need to continue to act on the international platform. Thanks.
Yeah, thanks very much, Sherry. And I think a lot of the things you touch on is also related to timeliness of us being able to leverage the products collected by HEMANET, not 6 to 12 months from after they're collected, right? It's being able to be nimble and, prioritize certain analyses or evaluations quickly. And I think that requires, a lot of work on the back end that would pay dividends, not just for HEMANET, but probably for a lot of surveillance and public health activities across Canada. So thank you.
Can I add, Jonathan?
Yes.
In terms of the timeliness, the WHO recommends a policy called 717, and that's 7 days to identify a newly causative agent, 1 day to notify, and 7 days to launch a response. In Canada, is that something that we're able to do? And I think a network like this will help us to better, have the metric to see if that's where we're landing. Thanks.
Right. The Tom Frieden, I think, as well as the 717.
Resolve, yeah.
Exactly.
Yeah.
So, thanks, Sherry. So I'm going to open Q&A for me or any panel members. If I don't like a question you ask, I reserve the right to not respond. No, I'm kidding. Or dodge the question expertly. Yeah.
Thanks very much. And I'm just going to disclose my prowess in finance. I know the word credit and debit. It's Thank you so much. That was really good. So I was just wondering, so just to hit the point on the non-communicable diseases point, A1 for sure. This is even what Canadians are asking for, right? They're kind of like, we're sick of infections. What about my chronic disease? So it kind of feeds into that, if that's what drives you sometimes. But I'm wondering, how much contact are we getting, Hemonet, with the experts associations in those fields? So the Canadian Diabetes Association and all the researchers, Nash, who's in charge of who leads the liver disease and so on, because there's they'll have all those numbers on the real hard numbers on what could be saved and so on. So that and if you have that kind of those kinds of associations or people on your paper saying like, this is, you want to know the value added, they might not need to hear it from Hemonet folks. They might also need to hear it from those associations, the ones who are leading those research fields, and they're ready to join you as a partner. So I continue to encourage Hemonet to reach out to them, in particular because if we knew how to screen for liver disease, oh my God, we will crush the healthcare system, 1 in 4 Canadians, okay? But can it be something we can screen for in the blood so readily? I wish we could. So that's why we need to really make sure we talk to those experts, because, Sheila and I were talking about this before, and we almost kind of scrapped it because it's very challenging to identify who should we be sending to a hepatologist, and there's already a 2-year wait list. I don't know what it's going to look like for Canadian diabetes or for finding diabetes. So the leads of these places will tell you, yeah, it would be great. You're going to crush us. So I think there has to be an awareness too of like, careful what you find, and it's great. It'll incentivize to invest in more diabetes prevention and so on. But at the same time, you've just identified, 20,000 new diabetics. So what are you going to do for that? So just comments.
Well, thank you very much. All very valid, and we haven't explicitly engaged with any of those networks, so that's an excellent suggestion.
Can I ask? Sorry. And I just maybe to go on that comment a little bit, but I had another question. Is even when we talk about like serosurveillance for HIV, which hopefully is not anonymized, and things like that, I think when we have these conversations in BC, it's also the question of linkage to care. It's don't come to me with a serosurveillance program, tell me I have HIV, and then have no way to deliver antivirals. So I think it's a huge discussion that should also be part of this group. And then the other thing that I haven't necessarily really heard, but I was just thinking about when you were talking, is we've been talking about emerging diseases, chronic or infections, chronic diseases, others. But a lot of there were a lot of CITF funded studies that measured vaccine responses in the real world, and there must be using your skills some value add of doing that, because. And I think, Kate, you said, the value of serosurveillance was noted when we didn't have a lot of PCR testing, we could do waves. But earlier than that, serosurveillance studies were showing that higher antibody titers when you had the longer amount of time between dose 1 and dose 2 for those nasty recommendations. So also just the measuring of vaccine responses that many of us were doing, and putting that, having those conversations and the value adds would be interesting.
No, excellent suggestion. I agree.
So I'm an ex-TB guy. I'm also on the strategy group, and I think maybe for Hemonet we need to decide that we're not just going to be chasing tests, but Stop TB, and you can correct me if I'm wrong, they state that for every $1 US that they get, they recover $43. So that's their statement.
Yeah.
So, when we're talking about cost recovery, if we can try, we probably can't get to $43, but if we can try to say what we could recover by not just doing a bunch of lab tests, but building a consortium that adds value to healthcare and delivery of healthcare, and then quantify it that way, I think that's how you get the bucks, right?
Of course, yeah, and that's so TB 1 to 43 globally, it definitely varies by burden. In Canada, we're definitely not going to get 1 to 43. The difficulty with our network, right? I started this project, looking at it exactly from that purview, like what do we need to get going, and then what's the value we're going to get back? But the value is so diffuse and tough to add a dollar value to, right? It's like and we need an army of like analytics people here to break down all the value pathways, quantify, averted disease burden. So we've kind of moved to a use case or example scenario where diabetes could be one, or waning immunity as another, where we can say, here's what we think is the capital cost and the ongoing cost going on, and here are a couple high value pathways that we can get in return. And it's one of these, like, I know if I treat you for TB, you have a very high probability of getting better and you will not transmit further, right? We can put in this network, generate this data, but if we don't do anything with it, all the value that we could potentially get from it is lost, and that could account to millions. So I'm with you. It's just, I've been struggling so much, and I'd love for help if anyone in here can like work with me to formulate this value and investment case more from just, here's a bunch of things that we could do, right? It's tough with a surveillance network as opposed to like a diagnostic and treatment intervention, rather than we're information generating at this point, right? That's our role here, in using it for public health action.
So maybe
Yeah.
your first step is just the qualitative pathways
Yeah.
that become outputs and you get the value later. I don't think when they started Stop TB, they said, we're going to save $43 in the world, right? I think that they probably said we need to stop TB because it's bad.
Yeah.
And then, we didn't do it, but maybe $43. So maybe the first step is just from those use cases, building out where you think the value pathways are and where you think you get more value and less value for each of the cases.
Yeah, no, I agree. Actually, that'd be a good way to frame it, and we can highlight, those exact high value use cases in the white paper. The return on investment's over $90, by the way, in Kenya, but only about $10 in Brazil, for example. Just by the way, yeah, it averages out. Yeah. Exactly. Big value, though. It's a shame that it's still severely underfunded globally. Anyway, I'll stop talking about TB.
I was going to comment that, first of all, I completely agree that, we do need to build a network that's, nimble and able to respond quickly. But at the same time, I also want to put a plug for building a network that also can withstand the test of time and actually accumulate data over time to monitor trends that might not be apparent very quickly. So, for example, recently there were new alcohol guidelines that came out, and I just recently heard as well that one way to promote adherence to the new guidelines is through encouraging the use of mocktails instead of alcohol. And mocktails are extremely high in sugar, which really made me wonder whether that's, like an appropriate substitute, So, do you monitor for, rates of diabetes over the long term to see if there is any connection, etc.? So just really have that longevity going forward.
Yeah, no, that's a great idea, and I would hope our biobank is length, or we're developing some sort of sampling system where if we're bringing a specimen from person X into the system, that we'd also be biobanking future samples from them to be able to monitor long-term trends. Okay, I see Tim at the mic, and I'm nervous now.
No, as a failed dismal scientist, I always love talking about economics. Very interesting, and it's a rich menu of value propositions that you put forward, and I think one of the really important things that you didn't mention, but is insofar as the maturity to find the value of these, and you gave some sense that sometimes, you don't realize the value of the resource that you've created until someone sees it 5 years later who's doing modeling of immune kinetics and says, like, we've made breakthroughs, right? Even though that wasn't the initial design and purpose. So in that context, it'd be very interesting, Jonathan, to get your views on how you would discount value into the future, and whether you think using regular discount rates that we use in economics are appropriate, or whether in the context of sort of environmental discounting, we should perhaps consider a negative discount rate. So that's a little bit of a economics issue. A second dimension, which might be part of this, is to look at the costs of inaction. And there are two dimensions of that I think are important. One is that there's a cost associated with not perhaps of the cost of inaction, meaning that the amount of time it took for us to get a pan-Canadian picture of what's going on in an emergency, right? So that's one cost. You could say that we're awkward and expensive, and we have real data on that. And you could say that if we harnessed the lessons now and we were to have a similar emergency in the future, then we could, in terms of time and cost, because we'd made investments, you could get some sense of that might be one dimension of the cost of inaction. But a second one that I think which is less specific to us as a network, but relates to the counterfactual, which is how does Canada do surveillance now? I think is really important, because that cost of inaction related to simply carrying on with what looks to be a very fragmented, patchy approach to what I'd say either singular disease or singular constituency or singular issue type of surveillance is another calculus. And I think if we're saying that part of the value of what we're proposing is that this is going to allow us greater efficiencies, then that comparison, I think, is worth pursuing. And I'm impressed that you got that much data out. But I think there is, because, and this will be my final comment on this, but it relates to somebody who's done a lot of work in cost effectiveness over my career. Most of the cost effectiveness analysis has been done with respect to interventions related to tuberculosis or other things. Very little cost effectiveness on public health interventions related to surveillance or active surveillance. And to me, part of what you might be proposing here as an entry point is that we actually shine the resource constraint and return on investment analysis a little bit more systematically on what we're doing in public health. And that might be particularly attractive in the context of transitions in government, where public sector budgets are going to come under greater scrutiny. That if we move as part of this towards valuing these things in such a way that we can say, actually, if we wanted to be more effective and generate more value in surveillance in Canada and go from 74 platforms to 7, right, then this is what we might, this might be the ROI, and that's why this might be so much more cost effective than what we're currently doing. So that's a long-winded way of encouraging you to continue in that analysis of what's actually being done in surveillance at the moment, and continue to generate that comparison.
Thanks so much, Tim. I know I'm out of time. I will give you 2 or 3 quick responses. On the one on the counterfactual of the emergency, what would have happened if we had this up and running during COVID? I know Caroline and I have talked a good bunch about that, the example of BC, if we had something going on there already, Canada-wide, what could we have done using the data from BC? In respect to the counterfactual in peacetime, I think I'm going to have to send a few emails to FAC and maybe try and get some information from them, and then maybe to every single Ministry of Health of every province to see what kind of resources they spend on surveillance. Here in Quebec, if you could tell me who heads up tuberculosis surveillance, I would be very grateful. It's usually some random person in Montreal Public Health that does it for the whole province, which is surprising. And I agree on the ROI. If we can do that for surveillance, a public health intervention, it would be game changing. I think it just hasn't been done because it's tough, obviously. But if research was easy, everyone would do it. So So it's a worthwhile effort. I stole that one from my mentor here at McGill, so I can't take credit for that saying, but yeah. Anyway, any comments from the panel or? No?
I think there's a comment.
Oh. Okay. So, Lori? Yep. I'll use my moderator prerogative to go over time. You can unmute and ask your question. Oh, maybe she can't hear us.
Oh, I can hear you now. Thank you.
Okay.
No, just a suggestion that maybe our colleagues in the poison centers and the Tox LRN network, Laboratory Resource Network, that is pan-Canadian, might have some value add options that we could look at for the surveillance that they've successfully been doing around poisons. Thanks.
No, great idea. Thank you. Okay. I'm going to thank my panel members and all of you for your attention. I think I'm supposed to pass it to Tim to keep us here for at least another hour. Yeah.
Thank you. All right. Okay, so just I can't resist one comment on value of early detection, and it has to do with mpox, but it's this issue of detecting things that may be bigger problems in the system. So we had the public health CDC Epi-Intelligence Service officer from Minneapolis with us at the School of Population and Global Health in the fall, talking about mpox. And she's done all this great research looking at mpox in the United States. And sure enough, it is gay and bisexual men who have sex with men that are at greatest risk. But in the United States, it's black gay and bisexual men who have sex with men, and also who have HIV that's not diagnosed. So here's this issue of a whole constituency that are flying under the radar screen, are off the radar screen of public health, right? They're not being detected, and they're actually the correlate in the study that she showed us is amazingly powerful. And so I think this issue of bringing attention to things that we're missing, because still our surveillance system, it goes back to the true denominators, the true picture in the population. We're really seeing what gets into the system in so many surveillance systems, what comes into the clinic. And, the United States has a much bigger problem than we do at that, but 20% of our population doesn't really have access to a primary care provider. I was on a call at lunch with somebody who's working in the international community, who's lived in the United States, Switzerland, and the UK in the last 3 years, and has, in each of those locations, has been unable to sign up with a primary care provider. In each of those locations, right? So the point being that I think that some of these are sort of resources that help us to understand, issues which are purposely built systems that you're supposed to go to actively, are not helping us with. So that's just my little editorial that I thought I'd share. Before I thank you all for a terrific first day. We've had Lori, who's even joining in from the airport, on her way. I hope Flair Air is going to give you the appropriate Valentine's support. But just to say that I do appreciate everybody making such an effort today. Please extend thanks and gratitude to your families who are probably, without your presence, for some cases like me, they sort of like that, but for most of you, I'm sure you're greatly missed. And then tomorrow we will start at 8 a.m. promptly. We have Maria Vankerkova from WHO who's going to give us a sense of the world of serosurveillance from her perspective, and she's unlike a lot of WHO bureaucrats, she has a massive experience in serosurveillance going way back. And so I think that should be a great start to the day. So we look forward to you joining us sharp at 8. There will be nutrition starting at 7:15. Breakfast, and so your blood sugar levels are in good shape. And so with that, have a wonderful evening. And again, thanks for a great first day. Cheers.